I readily acknowledge that cardiac iron overload in MDS patients is detectable by magnetic resonance imaging only after patients have received about 75 or 100 units of red blood cells. But cardiac function may be more vulnerable than liver function. We should be aware of that. So probably not so much iron is needed in the heart to cause damage. And this is supported by data that were derived from animal studies and from echocardiographic examinations in patients. And let me quickly explain this complicated slide. These orange dots are assessments of cardiac function by looking at left ventricular ejection fraction. And as you can see here, if cardiac T2 star, which is a measure of iron overload, is below 10, then you get into a very dangerous zone where cardiac failure is very likely to occur. And this blue danger zone starts at a cardiac iron tissue concentration of about 2 milligrams per gram dry weight of cardiac tissue. And this level of cardiac iron, of tissue iron concentration in the heart is much lower than the critical level of tissue iron concentration in the liver. In the liver, you have to have about 15 milligram per gram dry weight of liver tissue in order to expect liver cirrhosis. So this may mean that clinically relevant cardiac dysfunction occurs at lower tissue iron levels than clinically relevant liver dysfunction. So the heart may be more vulnerable than the liver. So you probably do not need that much iron in the heart to be at risk of developing cardiac complications. I would also like to point out that iron toxicity in MDS may not only depend on the degree of tissue iron accumulation, but may also be related to the extent of chronic exposure to non-transferrin-bound iron and labile plasma iron, because these generate reactive oxygen species. And non-transferrin-bound iron appears when the plasma iron exceeds the transferrin binding capacity. And part of the non-transferrin-bound iron is called LPI, labile plasma iron. And LPI is defined as being redox active, chelatable, and membrane permeant because it is readily taken up by cells in several parenchymal organs. Now, NTBI in the blood is usually not detectable, but NTBI in the serum is apparently of great clinical relevance. And this view is supported by the clinical experience in thalassemia major patients. The experience in thalassemia major tells us that patients going into heart failure can be rescued by intensive chelation therapy before much iron has been removed from the heart. And these benefits of continuous deferoxamine treatment on heart function occur before changes in T2 star visible storage iron, which is consistent with early removal of a toxic labile iron pool within the myocytes. And together, these observations suggest that substantial clinical benefit can be derived from detoxification of non-transferrin-bound iron. I think that cardiac dysfunction plays an important role in this whole situation. Partly as a consequence of chronic anemia and partly as a consequence of transfusional iron overload. Therefore, our best supportive care strategy must be twofold. On the one hand, we must use blood transfusions and erythropoiesis-stimulating agents in order to avoid the detrimental effects of chronic anemia. And at the same time, we must try to make sure that the beneficial effects of transfusion therapy are not offset by the detrimental effects of transfusional iron overload. and therefore we must use iron chelation therapy. And not only the heart may benefit, but also the circulation, the blood vessels may benefit. I came across this paper in the British Journal of Hematology looking at thalassemia patients treated with deferrazirox for 1 year. And the colleagues looked at brachial artery flow-mediated dilation, which showed a significant improvement over 12 months. And they also looked at a carotid arterial stiffness index, which showed a significant decrease over 12 months. So there was a significant defect of iron chelation therapy, which was attributed to the ability of deferrazirox to bind labile cell iron pools in the vascular wall, thereby diminish reactive oxygen species formation, and thus attenuate the inactivation of nitric oxide. And nitric oxide, as you all know, is a very potent and useful vasodilator, which should not become depleted. So we might perhaps add vascular damage to our list of possible complications of iron overload. I do not think that in elderly MDS patients, iron overload causes any dramatic, eye-catching effect in one particular organ system. Instead, I'm convinced that it is the simultaneous aggravation of several common causes of death in the elderly that may add up to a strong cumulative effect. However, even if this effect is substantial, it may easily hide behind those usual causes of death in the elderly. And therefore, I think it is rather difficult to precisely measure, to precisely define the contribution of iron overload to the morbidity and mortality in MDS, because the complications of iron overload are so similar to the usual causes of death in the elderly. And this makes it very hard to distinguish between the contribution of iron overload and the usual causes of death. If we incriminate LPI, which causes oxidative stress, we should be sure that LPI levels are actually elevated in MDS, and they are elevated, not nearly as high as in thalassemia major, even at comparable serum ferritin levels. But they are elevated. Now, we think that LPI levels may do their damage through increased oxidative stress. And in fact, increased oxidative stress has been documented in MDS. But the question is, how much of that oxidative stress is due to iron overload, and how much of it is an intrinsic property of the abnormal MDS clone? And that's another very difficult question. But I think it is intriguing that in this investigation from Israel, there were changes in oxidative stress parameters in blood cells during a 3-month treatment with deferrazirox. During this 3-month iron chelation therapy, the level of reactive oxygen species significantly decreased, and reduced glutathione, which is an antioxidant agent, was replenished during the treatment. So I think this is quite a strong argument that there is actually oxidative stress dependent on iron overload, and therefore amenable to treatment with iron chelation therapy. Now, if we want to successfully suppress non-transferrin bound iron, we have to use a chelator that is present all the time. And this is nicely illustrated in this slide. With continuous infusion of deferoxamine, you get a nice suppression of non-transferrin bound iron. But as soon as the infusion is stopped, NTBI shoots up again. And this is also illustrated in this slide. On the left-hand side, you can see labile plasma iron, which is nicely suppressed during the night with nightly desferal infusions, but LPI levels spring up again in the morning. You can use an oral iron chelator like deferiprone, which has to be given 3 times daily, and you can get suppression of LPI, but the levels rebound between doses. You might even combine desferal at night with daily administration of deferiprone. And of course, you get a better control of LPI levels. But with this combined treatment, of course, the patient treatment burden is considerably increased. The situation looks much nicer with the oral ion chelator deferrazirox, because this drug has a long half-life, which provides 24-hour chelation coverage. And it does work to successfully suppress LPI levels. And there are 2 independent studies that have shown this. One is the US03 trial, and one is the large EPIC trial. And in both trials, those patients who had elevated LPI levels at baseline showed normalization of LPI levels after 3 months when it was first measured. So the long-acting iron chelator does successfully suppress LPI levels.